So today we are going to talk about a very interesting topic about calcium physiology and assessment, which is extremely important from a pediatrician's perspective because a lot of these calcium disorders present to us in an emergency setting like hypocalcemia or hypercalcemia, but also we can have situations wherein they can manifest other chronic conditions like rickets. So what we'll do is that we'll start off with the introduction briefly, and then we'll talk about the basics about calcium physiology, because this is one area which has caused a lot of confusion, and that is very, very important to understand the pathophysiology, which we'll discuss. And finally, we'll go individually about how each and different aspects of calcium physiology should be assessed and managed in that perspective. And then we have a few announcements to make, which we'll talk about in the end of the discussion. Today we are going to use the Zoom platform, so we have the option of online polling as well. So we will be asking questions in the form of polls, which you can answer in this situation intermittently, and we'll just keep it more interactive in that perspective. You can post your question and answer, which I'll answer at the end of the webinar. So as discussed, this is part of our learning initiative as far as MedEClasses, which is providing information with regards to various aspects of pediatric endocrinology in the form of various modules. And we have the online and the on-site course, which is available from our site. So without wasting any further time, we'll start off with the calcium physiology and assessment aspect, which is extremely important. So we'll start off with physiology. And what we need to understand is that circulating calcium basically represents less than 1% of the entire body calcium. 99% of it is actually stored deep in the bone. So that 99% of calcium is actually, in a way, not available for the body, and the bones cannot use it. Now, this calcium, which is in the circulation, can either be bound to albumin, which accounts for around 40%, or to other negative ions like phosphorus, which accounts for 10%. And we have this 50% approximately, which is the ionic calcium. And it is this ionic calcium, which is the active form of calcium. And basically, if we have abnormalities in the binding, in which we have more binding to albumin or more binding to phosphorus, we will have situations of ionic hypocalcemia despite having a normal level of serum the level of phosphorus. Now, one of the major determinants of calcium binding to albumin is the pH. So situations associated with metabolic alkalosis are associated basically with increased amount of negative albumin, resulting in ionic hypocalcemia. So this is extremely important in two clinical settings which we see often. So if you have alkalosis, that will result in ionic hypocalcemia, particularly if there is hyperventilation. So if we have a newborn who has been hyperventilated, will have respiratory alkalosis, and that will result in a lower level of calcium, and which may actually be detrimental as far as the muscular strength is concerned. So one needs to avoid hyperventilation for this important reason. And second extremely common situation is the setting of use of soda bicarbonate, particularly in the setting of a renal failure, in which somebody has having a borderline calcium stored, and all of a sudden if we give soda bicarbonate for correction of acidosis, we may have increased ionic albumin which is there, and which will result in hypocalcemia. So this is the situation which is something which we need to be very careful about in this perspective. And at that point of time, we would like to launch our first poll. So which of the following increases ionic calcium levels? So we have options in the form of hyperventilation, metabolic acidosis, hemolysis, and rhabdomyolysis. So I think we'll relaunch it, and you have the option to fulfill. So now you can answer, which of the following will result in increased level of ionic calcium? Is it hyperventilation, metabolic acidosis, hemolysis, or rhabdomyolysis? So I think we'll end the poll there. So what we see clearly is that metabolic acidosis is definitely a situation which will cause decreased binding of calcium to albumin, and therefore will result in higher level of serum calcium. Having discussed that, the next issue is that we'll now go through the cases which will tell us about in terms of what would be the situation. So we'll Now going to this case, a 4-year-old boy, 4-month-old boy with nephrotic syndrome, who basically presented with ionic hypocalcemia with calcium levels of 7.2. The child was otherwise asymptomatic. So first thing, of course, in this setting is to look at albumin. And we have discussed that albumin is the major determinant as far as the binding of calcium is concerned. So in this child, the albumin levels were low. And for this, we need to correct. So for every 1 gram decrease in albumin, we can add a 0.8 to the calcium in terms of milligram per dl. And that's why we can use a corrected calcium, in which we found in this case to be 8.8. So everybody who comes to us with hypocalcemia, we should ideally be doing an ionic calcium. But if that is not easily available, we can correct it for albumin, and that would be a reasonable way to go forward in terms of the situation. Now, this is a 6-year-old girl with chronic kidney disease. And what we see is that she had metabolic acidosis and was given injection bicarbonate. And all of a sudden, she had a tetany. So what do you think would have gone wrong in this setting, and what could explain this sudden development of tetany in this situation? So of course, this child actually has a borderline calcium state, because we are dealing with somebody who has a chronic kidney disease. We've given bicarbonate. With bicarbonate treatment, the ionic amount of albumin is increasing. There will be more binding of albumin to the calcium, and therefore there will be hypocalcemia. So this is the typical effect that we see. So we should be avoiding giving unnecessary soda bicarbonate in this setting. Otherwise, it will cause definitely hypocalcemia, as in this case. Now, we talk about calcium homeostasis. Again, so we are talking about 3 major organs and 3 major hormone glands. So we have the intestine, the bone, and the kidneys, and we have the calcitonin, calcitriol, and PTH, which are the major regulators as far as the calcium homeostasis is concerned. We'll go one by one with regards to everything. So the main issue now we need to ask is, which of these is the most important? So if you want to know one compound or one hormone which is the most crucial as far as calcium metabolism, it is the parathyroid hormone, and the least important is calcitonin. Calcium levels in the body is sensed by calcium receptor, which then signals the PTH that we have low or high calcium to decide about the PTH secretion, and the urinary calcium. And this we'll discuss is a very important situation wherein disorders of calcium sensing receptor will result in bizarre situations of hypercalcemia with hypocalciuria and hypocalcemia with hypercalciuria. So calcium sensing receptor is an important mediator, so to speak, about telling the body how much calcium is there and how do we adapt to that. So now in this perspective, the intestinal absorption is an important situation, and we have got 2 modes of intestinal absorption. We've got calcium which is there largely in milk and dairy product and green vegetables, and this calcium can go through the gut either through a paracellular mechanism or through an active transport. The absorption of calcium is adversely affected by the intake of phosphorus. So if we are taking any phosphorus-rich medication, it would really impair the calcium absorption, as well as the intake of the various carbonated drinks, because that will cause decreased absorption of calcium. Now, presence of phytate, particularly in a vegetarian diet, is also an important inhibitor of calcium absorption. Now, this calcium can go directly through the cells, which is the paracellular mode of transport, which does not require any active transport mechanism, and this is not regulated. So what it tells us is that this, if we have higher intake of calcium, can result in hypercalcemia. So situations, what is known as milk alkali syndrome, if we intake a huge amount of calcium, it will actually result in unregulated calcium paracellular transport, causing hypercalcemia. On the other hand, the active transport of calcium plays a very important role in regulation of calcium levels, particularly in deficiency. And most diets actually are deficient in calcium. Now, this calcium is transported through the gut using the active transporters. Once inside the enterocyte, we have the vitamin D dependent action, where calcitriol causes action to the vitamin D receptor to produce calbindin D, which is basically a transporter protein of calcium, which takes this calcium from the luminal site to the side where the blood vessels are, and from there this calcium is taken off from the basolateral part. So the calcium active transport is largely regulated by calcitriol, and it would increase based upon the vitamin D status. So in situations where there is vitamin D deficiency, only 25% of the ingested calcium is going to be absorbed. While if we have a sufficiency, we will have around 40% absorption, which will happen in this perspective. So vitamin D status is an important determinant of how much calcium will go through the active transport. And this active mode is very important in most Indian children, because the calcium intake is not more than 500 to 600 milligrams per day in a large number of children, as against the desired or the recommended amount of beyond 1200 or 1300 milligrams. So therefore, this active transport becomes extremely important in this situation. It also increases during adolescence, and particularly during pregnancy and lactation, to ensure that there is enough calcium in the body. Growth hormone and estrogen, again agents which cause bone growth, and of course if you're causing bone growth you need more calcium, will result in increased amount of these levels. While glucocorticoid and thyroxine cause decreased calcium absorption. And we need to remember that glucocorticoid, if you look at it, is basically an anti-calcium hormone, so to speak. So if you have more glucocorticoid, you will have less vitamin D, you will have less calcium absorption, you will have less bone resorption, you will have less bone formation. So it will have a massive impact on not only the calcium homeostasis, but as well as the skeleton. So individuals who are on steroids, be it nephrotic syndrome, be it autoimmune diseases or any other conditions, should always be supplemented with calcium and vitamin D to avoid detrimental short-term and long-term impact on bone physiology. Now talking about the exchange as to how we are able to maintain this calcium level. So the acute homeostasis of calcium level is largely done at the level of skeleton. The chronic homeostasis occurs at the level of the intestine and the kidneys, but the acute homeostasis is mainly in the skeleton, because 99% of all calcium is actually there in the bones. So which is available as the calcium hydroxyapatite. Only 1% of which, as we discussed, is exchangeable with the serum, and this calcium can be shifted from the bones to the circulation by the parathyroid hormone, which is a resorptive hormone, while we can have calcitonin, which will cause the calcium to go into the bones. So calcitonin has a very minimal physiological effect, which we'll discuss later on. And in this situation, what we're looking at basically is that this calcitonin can be helpful in situations of hypercalcemia, while PTH will cause increased calcium level, and of course, absence of PTH will cause severe hypocalcemia in this perspective. So now I think we'll just take the second pole in this situation. So the question now is that which of the following is the most important regulator of calcium levels? Is it PTH, calcitonin, calcitriol, or PTH-related peptide? So you can now just give the answer. And this we have discussed now with regards to the ways in terms of how the various different endocrine systems play an important role in terms of regulation. So we got one answer about calcitriol. So is it PTH, calcitonin, calcitriol, or PTH-RP? So now what we do is that basically, just to remember, is that the most important regulator of calcium homeostasis is actually parathyroid hormone, because parathyroid hormone also plays an important role in regulation of calcitriol. So PTH is the most important aspect in terms of evaluation and in terms of management and pathophysiology of calcium. So now we'll move forward to the next aspect of the second major organ in terms of calcium handling, that is the kidneys. And kidneys play an important role in chronic regulation of calcium homeostasis. So if you have hypercalcemia, the kidneys will result in loss of calcium. And most calcium, which is actually filtered off in the kidney, is actually reabsorbed at the level of proximal convoluted tubule. And this is regulated by the calcium sensing receptor. So if the body has got more calcium, the calcium sensing receptor will sense it and tell the kidneys, okay, resorb less. So high calcium sensing receptor action causes hypercalciuria. On the other hand, if there is hypocalcemia, you would expect the calcium sensing receptor to be work less, resulting in more resorption of calcium. So generally speaking, if you have hypocalcemia, you should have hypocalciuria. And if you have hypercalcemia, you should have hypercalciuria, which is simple. High serum calcium, high urine calcium, low serum calcium, low urine calcium. But if you have some abnormality in the calcium sensing receptor, suppose this calcium sensing receptor is not working, what will happen is that body's calcium levels will increase, but the kidneys will not sense it. And therefore, you will have a situation of hypercalcemia with hypocalciuria. On the other hand, if you have a activating mutation of the calcium sensing receptor, the body will sense that the calcium is low. You will have, body will sense the calcium level is high. You will have hypocalcemia, but the kidneys will also sense that you have high level of calcium, so there will be hypercalciuria. So this will be hypocalcemia with hypercalciuria in this situation. Now, a very small 5% amount of calcium which is actually there is delivered to the distal tubule and all of it is absorbed. So basically, pretty much the urinary calcium excretion is not significant. If it's in fact more than 4 milligram per kg per day, it would be considered as hypercalciuria. Now this distal absorption, which is around 5%, 95% has already happened in the proximal tubule, is regulated by the active transporters, which are TRPV5, and it is regulated by PTH. So the two major regulators of calcium excretion are the calcium sensing receptor, which acts in the proximal convoluted tubule, and the parathyroid hormone, which is largely acting on the distal tubule. Now this effect of PTH in the kidneys is different from its other effect on the 1-alpha hydroxylase, which is primarily in the proximal convoluted tubule. So parathyroid hormone increases 1-alpha hydroxylase action, which we'll discuss later on in vitamin D physiology, causing increased level of calcitriol in the proximal tubule, and it also causes a increased calcium resorption at the level of distal tubule. So if one has a hypoparathyroidism, PTH is low, it will not act on the proximal tubule, so there will be low calcitriol and there will be hypocalcemia, while it will also not act on the distal tubule and there would be relative hypercalciuria. So hypoparathyroidism is a state in which there is low calcium but a tendency to increase calcium excretion. This is in contradistinction to pseudo-hypoparathyroidism, where there is a dichotomy in terms of PTH action. So the PTH action in the proximal tubule, where it is actually producing the calcitriol, is defective, so there is hypocalcemia. But the effect on the distal tubule is not defective, so there is no hypercalciuria. Now this has major implications in terms of management of hypoparathyroidism versus pseudo-hypoparathyroidism. In hypoparathyroidism, if we build the calcium levels to above 8.5 or 9, there would be hypercalciuria and nephrocalcinosis, while such risk is not there with pseudo-hypoparathyroidism. So the targets of serum calcium levels in hypoparathyroidism are around 8 to 8.5, while we need to maintain higher calciums 9.5 to 10 in pseudo-hypoparathyroidism so as to avoid the overall situation of bone effects, which will cause bone resorption. Now calcitriol also plays a role in terms of calcium absorption, as well as the diuretics, the thiazide diuretics and the furosemide diuretic. The thiazide diuretic causes decrease in calcium excretion, so it is used in treatment of idiopathic hypercalciuria, while furosemide causes the opposite, it causes hypercalciuria. So long-term use of furosemide, particularly in the setting of newborns with chronic lung disease, may predispose them to hypercalcemia and nephrocalcinosis, which we need to be careful about. Now, PTH, as discussed, is the most important regulator as far as the calcium level is concerned. This PTH comes from the parathyroid gland, which is developed from the third and fourth branchial pouches. And it is these pouches which are also responsible for development of thymus. So therefore, thymic abnormalities, immune problems, cardiac abnormalities are quite common with parathyroid involvement, particularly in the setting of Dijot syndrome and catch-22 situation. So this PTH is basically because it's a large molecule, and as with other large molecules like ACTH, like insulin, they are preformed and stored in their cells. From there, it is converted into from pre-pro-PTH to PTH, and then it can either be degraded or released. So the regulation of PTH as for other large peptides is largely at the level of release and not synthesis. And the major determinants of release are magnesium and phosphorus. So hyperphosphatemia will trigger the PTH to increase, and that will cause the PTH action. And this is responsible a lot in the setting of renal osteodystrophy, while magnesium plays an important role in regulation of PTH. So if you have hypomagnesemia, there will be less PTH, and that is why we have to rule out hypomagnesemia invariably in every child who presents to us with hypoparathyroid-like state. Similarly, fibroblast growth factor 23 and calcitriol actually decrease PTH release, and if you have more FGF23, you will actually have low PTH. This is important because both of these will cause phosphaturia, and therefore you will have very low phosphorus if it actually stimulates that. Now this PTH acts on the PTH1 receptor, which is the same receptor also for the PTH related peptide, acting through the GNAS system, which is the G protein system in the kidneys, and in the kidneys it causes decreased calcium absorption, decreased calcium excretion, and increased phosphorus excretion. So hyperparathyroidism causes hypercalcemia and hypophosphatemia, while hypoparathyroidism will cause hypocalcemia with high phosphorus level. PTH is also important in increasing the 1-alpha hydroxylase, as we discussed, predominantly at the level of the proximal tubule. So it plays an important role in the calcium absorption. So in a nutshell, PTH causes high calcium, low phosphorus, and its role is also controlled by the calcium sensing receptor. It increases calcitriol through the 1-alpha hydroxylase pathway, and therefore you will have increased absorption of calcium. There will be more calcium resorption at the level of bone. So it actually affects all the three major organs, the intestine, the bone, and the kidneys in terms of calcium metabolism. So now we have a 10-year-old boy with seizures, ionic calcium of 2.1. So there is hypocalcemia. Phosphorus level is not really high, but the PTH level is inappropriately low for this level of calcium. So this PTH may look normal, but for this level of ionic calcium, we would expect the PTH levels to be much higher. So there is a lower level of PTH for the level of hypocalcemia. There is no response to IV calcium. So what should be the next step? So can we have, you can use the Q&A section to use put the information as to what you think should be done in this perspective. So what do you think is the cause in this situation? So what we're looking here is a child who looks like hypoparathyroidism. The phosphorus is not very high. So what should be done in this situation? So as discussed, it's extremely important to look for magnesium in this situation, and we found that this was hypomagnesemia. So any child who has got a hypoparathyroidism should always considered to be a situation in which we can have a low magnesium as an important situation. So now we will move forward to the second important player in the whole calcium metabolism, and that is vitamin D. And vitamin D plays a very, very important role, particularly in the gut absorption. We'll discuss about the other roles. It is produced largely from the 7-dehydroxy cholesterol under the effect of UV light between 290 to 315 nanomoles, and it is converted into cholecalciferol, which is regulated depending upon a number of factors like skin color, latitude, season, timing, and level of pollution. So the requirement of sunlight exposure to produce sufficient amount of vitamin D will differ in different perspectives and different situations, particularly in the setting of the altitude, latitude, and the swelling. So normally in the Indian setting, we would be needing around 90 to 120 minute exposure between 10 to 3 p.m. and the best production is between 11 to 1 p.m. So this is the time when most people are indoors, and therefore there is a high prevalence of vitamin D deficiency in this setting. There is very small amount of vitamin D in the nutritional component in the form of mushroom and fish, and we need to have a huge amount to really produce enough. And importantly, plant sources produce ergocalciferol, and both ergo and cholecalciferol are termed as vitamin D. They are considered to be similar in terms of their impact, but there seems to be a greater effect in terms of cholecalciferol as compared to the ergocalciferol in terms of effect. So now we'll discussing further about the vitamin D pathway. We've discussed already how the various nutritional aspects are important. We have the ergocalciferol and cholecalciferol, and both of them we will label as vitamin D. And this vitamin D will be then transported predominantly through the vitamin D binding protein to the liver, where they are 25 hydroxylated to 25 hydroxyvitamin. Now this 25 hydroxylase is a unique enzyme in which that its level are not inhibited by the level of its product. So 25 hydroxyvitamin D does not inhibit 25 hydroxylase production. So the level of 25 hydroxyvitamin D reflects the actual vitamin D status, and therefore it is considered to be the best marker of vitamin D status. It is then converted via 1-alpha hydroxylase in the kidneys into calcitriol, which is the active form of vitamin D, which is regulated by PTH. So hyperparathyroidism will cause more vitamin D production, and it is inhibited by the FGF23, which we'll discuss subsequently. Very importantly, there is extra renal production of 1-alpha hydroxylase, particularly in the macrophages, and this is responsible for causing hypercalcemia in situations where there is macrophage activation syndromes like subcutaneous fat necrosis in newborn period, or sarcoidosis, or tuberculosis, or other granulomatous diseases. Excess vitamin D is inactivated by the enzyme 24-hydroxylase into 24-25 hydroxyvitamin D, and drugs which activate vitamin D inactivation, like anti-epileptic drugs, are known to therefore cause osteomalacia, vitamin D deficiency, and rickets. So therefore, any child who is on anti-epileptic drugs should be given regular supplementation of calcium and high doses of vitamin D. Vitamin D, as discussed, plays a very important role in absorption of both calcium and phosphorus. It also plays a role, as discussed, along with PTH in the distal absorption of calcium, and a mild role in bone formation. So if one has enough amount of calcium, vitamin D will go to the mode to form bone. On the other hand, if the calcium store is less, it will cause bone resorption. So while PTH plays a very important role in regulating both skeletal, renal, as well as intestinal absorption, vitamin D also has a pleiotropic role, and that seems to be pretty important in this perspective. One key message to give is that breast milk is an extremely poor source of vitamin D, and we would need 8 liters of breast milk to have enough vitamin D, which is the recommended allowance of around 400 international units per day. So therefore, most breastfed or all breastfed newborns should actually be supplemented with vitamin D. So vitamin D in a nutshell causes high levels of calcium and phosphorus, as against PTH, which causes high calcium, low phosphorus. So in hypocalcemia, you will have increased level of 1-alpha hydroxylase to produce more amount of vitamin D, and you will have less 24-hydroxylase so as to avoid excess metabolism of vitamin D. Similarly, in the setting of hypercalcemia, you will have low 1-alpha hydroxylase and increased 24-hydroxylase action in this situation. So now we have a 4-day-old child with seizures. What we are seeing is that the child had birth weight of 3.2 kgs, had asphyxia, calcium level is 18. So here we have a child who has severe hypercalcemia, phosphorus is normal. Remember, if you have hyperparathyroidism, the calcium will be high, but the PTH level will be on the lower side. So this, the phosphorus level will be on the lower side. So this child has hypercalcemia and normal phosphorus. So what we need to look at, we looked at PTH, which was low, which is expected given that the phosphorus levels are not really low. So now we are dealing with a PTH independent cause of hypercalcemia. So in this situation, the next step is of course to look at vitamin D levels, which were not high. So there is of course no vitamin D given outside. How would the levels be high? So what is happening in this 4-day-old boy who is presenting to us with severe hypercalcemia, undetectable PTH? So what we found was that the calcitriol level were high, and this child, which suggests that there is some increased conversion of 25 to 125 hydroxy vitamin D, and this was confirmed when we examined the child actually had palpable nodules, and this was suggestive of fat necrosis. So subcutaneous fat necrosis is an important cause of hypercalcemia in the newborn period, and these are like violaceous nodules which will be there in multiple parts of the body. Treatment usually is with steroids, short course of steroids, and they will improve over a few weeks of life. 15-year-old girl, preterm, 28 weeks of gestation, and this is a very interesting case. What we are finding is that the child actually has hypercalcemia, phosphorus levels is low. And what we expect that the PTH should be high. So this is hypercalcemia with hypophosphatemia, but the setting is a bit strange. It's a preterm delivery, 28 weeks of gestation. The PTH level was found to be low. So this is again a PTH independent cause. Vitamin D levels were low and calcitriol was increased. So this is a very interesting situation. When we were discussing about the 1-alpha hydroxylase and we talked about how the hypocalcemia causes increased 1-alpha hydroxylase, similarly hypophosphatemia also increases 1-alpha hydroxylase. So in newborns, particularly those who are on TPN, who have less phosphorus, will produce more 1-alpha hydroxylase and would be at higher risk of developing hypercalcemia, and this hypercalcemia will be corrected if we give phosphorus in this setting in most situations. So this was a case of TPN associated hypophosphatemia which resulted in secondary hypercalcemia. Now we talk about the third player in the calcium metabolism, which is calcitonin, and as discussed, calcitonin is a minor player in this perspective. So calcitonin causes calcium to go into the bones, so it's a good drug to treat for hypercalcemia. The only problem is that there is a tachyphylaxis which happens. So if you're using it for a longer duration, its effect will go off. It will also decrease the level of calcitriol, increase calcium excretion, and therefore this causes the opposite of PTH. It causes hypocalcemia and hyperphosphatemia. But calcitonin has a very minimal physiological effect. The reason being that situations like medullary carcinoma thyroid, where there is a huge amount of calcitonin, we would expect hypocalcemia to happen, but there's no hypocalcemia. Similarly, when you're having a thyroidectomy with an intact parathyroid, you do not develop hypercalcemia. So therefore, calcitonin is more of a player which plays a role when there is hypercalcemia, that too for some time. And in the absence of it, it has a limited physiological role. And this goes with the concept that body is more concerned about hypocalcemia, and that's why PTH and calcitriol are the two players which are playing an important role, with limited role as far as calcitonin is concerned. Now, how does the body know what the calcium levels are and how they are working? The most important of this is the calcium sensing receptor. And this calcium sensing receptor goes to the parathyroid gland and tells, okay, now the calcium levels are high, we need to decrease the PTH level. And then it also goes at the level of kidney to say now the levels are high, we need to increase urinary calcium. So activation of calcium sensing receptor will result in a situation of hypocalcemia with hypercalciuria, while inactivation will result in hypercalcemia with hypocalciuria. So this is a 12-day-old girl with irritability, and what we find that she was dehydrated, high level of calcium, hypercalcemia was there, PTH levels were high. So this is the case we discussed about that child with subcutaneous nodule in which there was more calcitriol production. We discussed the second situation of hypophosphatemia causing hypercalcemia, but this is actually the most important, the most severe form of hypercalcemia in the newborn period. And we should think of it if there is dehydration, irritability, hypertension, constipation in newborn, look at calcium levels. They were high. PTH levels were high, so this is PTH dependent. So we did a urinary calcium creatinine ratio, which was not really high. And this goes in favor of neonatal severe hyperparathyroidism, which is a calcium sensing receptor defect. The way to screen is to look at parents. And what we found in this parent was they had mild hypercalcemia with hypocalciuria. Every individual with high serum calcium should have high urinary calcium. But this child's parents actually had high serum calcium and low urinary calcium, suggesting a calcium sensing receptor inactivating mutation. And this is the classical form, which usually will require initial stabilization, use probably of calcium mimetic agents, the use of cinacalcet, the use of hydration, diuretics, and subsequently surgery would be what is required in most situations in this perspective. So now just to summarize the calcium regulation, basically PTH and calcitriol both increase calcium. We only have one hormone which causes hypocalcemia. Phosphorus is decreased by PTH and increased by calcitriol and calcitonin. And urinary calcium is increased by calcitonin by both calcitriol and PTH cause conservation of urinary calcium. This is the way in which we need to understand. So usually if you have a PTH dependent hypocalcemia, phosphorus should be high. If there is a vitamin D dependent hypocalcemia, you will have secondary hyperparathyroidism and low phosphorus. So every child with hypocalcemia should have low phosphorus. If a child with hypocalcemia has a high phosphorus, we should think of a possibility of a PTH problem or a renal failure. 4-year-old girl with tetany, calcium, ionic calcium levels are low, phosphorus levels are really high, PTH levels are also high. It was diagnosed as pseudo-hypoparathyroidism. Now, do we agree? We've discussed that we expect a child who has a non-PTH related hypocalcemia to have hypophosphatemia. So if you have hypocalcemia, hyperphosphatemia, high PTH, most people will say this is like a pseudo-hypoparathyroidism. But does anybody of you not agree with this? Could this be something else in this situation? So can it be something else in this situation? You can use the Q&A option in this situation just to look for that. So this is a situation which we have to be very careful. Whenever you have hypocalcemia with hyperparathyroidism and high phosphorus, always rule out chronic kidney disease, because that is something which can really cause a situation like this and result in hypocalcemia. This is something which is extremely important to exclude. So now we've talked about the overall regulation as far as the calcium level is concerned. We'll now talk about fetal physiology and how this plays an important role. So from a fetal perspective, fetus for calcium is like a parasite. It takes extra calcium from the mother. So there is a gradient of calcium from mother to the fetus, which is negative gradient. For glucose, we discussed that actually the fetus will have lower glucose than the mother, but because of the active transport using these transporters, the fetus will have a higher level of calcium, and most calcium transfer happens in the third trimester. The PTH related peptide plays a very, very important role in terms of regulation of this, and it ensures that there is a gradient of 1.4:1. So basically what is happening is that in the pregnancy, mother's calcium absorption and calcium resorption from bone is increased, and this calcium goes to the fetus. And again, PTH-RP plays an important role, which is mainly produced at the level of placenta. So there is a very minimal role of parathyroid hormone and vitamin D in the fetal transport. But what we need to understand is that the fetal parathyroid axis is pretty active. So in this situation, if you have a mother who has hypercalcemia, fetus's calcium levels will go up and this PTH level will come down. Now, as soon as the birth has happened, you will have severe hypocalcemia. On the opposite, if my mother has hypocalcemic disorder, you will have low calcium level in the fetus, which will be maintained because of hyperparathyroidism. As soon as the fetal period is over and the child is born, there will be a risk of hypercalcemia. So like our diabetic mother may have hypoglycemia in the newborn, that is, there is a reverse change happening. Similarly, if there is hypercalcemia in the mother, that can cause hypocalcemia in the fetus in the newborn period, and if there is hypocalcemia, will result in hypercalcemia. So this makes a very important point. So if you have any newborn who has got hypocalcemia or hypercalcemia, always measure maternal level of serum calcium, because that could be one of the culprits. So now what happens after birth? The whole supply goes off, the calcium level goes up, the PTH level goes up, trying to compensate. The calcitonin, which is a hypocalcemic hormone, comes down, and calcitriol increases. However, this calcitriol plays a very limited role in calcium regulation in the first 2 weeks of life. So vitamin D deficiency does not cause hypocalcemia in the early newborn period, and it is responsible for late hypocalcemia. Therefore, we have a window of opportunity to work for 2 weeks, and that is the period in which we can act in this perspective. So what happens is that as soon as we have born, the calcium levels come down, and then these levels tend to increase. So this is this 24-hour, which is the nadir period when the levels really come down. And this decrease is much more significant with preterm newborns because the levels can be really low. So now we've discussed about the regulation of calcium. What does the calcium do to the body? So it plays a role in every part of the body to increase bone strength, nerve function, conduction problems in terms of heart, enzyme release in the insulin. So a lot of these intracellular signaling is dependent upon calcium levels, the effect of ADH. So therefore, if you have problems, you may have nephrogenic DI-like situation, particularly with hypercalcemia and gut motility. So it has an effect on every organ, and that's why we need to have a high index of suspicion for calcium disorders. So now we'll talk about the pathophysiology as to how this physiology translates into pathology. Just an overview. So we have 3 major organs: the intestine, the bone, and the kidneys. And we've got the 3 major hormones which play an important role. So PTH causes calcium to come out of bones, while calcitonin ensures that the calcium goes inside the bone. PTH also acts on calcitriol and pushes the calcium absorption from the intestine. And this calcium will be in the blood, or it will be excreted via the kidneys, and where again the PTH causes conservation of calcium excretion. Simultaneously, it causes increased phosphorus excretion. Calcium sensing receptor detects the calcium levels and tells the parathyroid hormone, okay, it is enough, we need to decrease secretion, and goes to the kidneys and says we need to increase urinary calcium. So this is how there is a whole interplay between the various players as far as calcium metabolism is concerned. Very importantly, magnesium plays an important role in PTH secretion, and therefore hypomagnesemia should be considered. So in this overall background, because this is more of a physiology class, we'll not talk much about pathophysiology. We'll just give an idea as to what can cause calcium disorders. So these can happen because of problems in bone turnover, problems in PTH, absorption, renal functions, chelation, and calcium sensing receptor. So if we talk about hypercalcemia, it can be because of high parathyroid hormone, malignancy causing PTH-RP production. We can have a rare situation in which PTH1 receptor is hyperactive called Jansen's metaphyseal dysostosis. There could be a problem in which there's a lytic lesion in the bone causing calcium to release. There could be thyrotoxicosis, which can also cause hypercalcemia. Use of drugs like vitamin A, retinoic acid can also cause increased bone resorption. On the other hand, if the bone formation is basically impaired in the setting of hypophosphatasia or immobilization, there will be less formation, more resorption, and therefore there will be hypercalcemia. Hypercalcemia can also happen if there is increased vitamin D intake, increased intake of calcium, low level of phosphorus, which will stimulate 1-alpha hydroxylase, or granulomatous disease, which will cause increased production of 1-alpha hydroxylase, which is extrarenal and not regulated by PTH, defect in the 24-hydroxylase, which is known as idiopathic hypercalcemia of infancy. Similarly, the use of thiazide diuretics can cause hypercalcemia and an inactivating mutation in the calcium sensing receptor. Now, hypocalcemia can happen if there is a problem in the parathyroid, hypoparathyroidism or pseudohypoparathyroidism, low levels of magnesium, activating receptor mutation, which will cause hypocalcemia with hypercalciuria, deficiency of vitamin D, chronic kidney disease or VDDR1, where there is decreased activation of 1-alpha hydroxylase, use of anti-epileptic drugs, VDDR2, in which there is a resistance to vitamin D action, chronic kidney disease at the level of kidneys. And so these could be the various causes which will cause hypo and hypercalcemia. Now in this setting, now we can understand what are the effects of these individuals' conditions. So the calcium levels go down, there would be problems like rickets causing decreased bone strength, there will be dysmotility, there could be excitability causing increased spasm and seizures, there would be cardiomyopathy, and this is particularly common with vitamin D deficiency. There could be hypercalcemia, will cause increased bone resorption because that's part of it. It will cause decreased bone strength. Constipation is an important finding because of gut motility effect. Very high levels will cause encephalopathy, hypertension and ECG changes, as we discussed for hypercalcemia. There could also be a pancreatitis because of severe hypercalcemia, polyuria and calcification, which will be because of a nephrogenic DI-like picture. So calcium disorders can have a huge impact in terms of overall outcome of these situations. So now the manifestations depend upon the serum levels of calcium. Generally, the symptoms are not there if the levels are between 8 to 12. Jitteriness starts happening somewhere around 7 milligrams per DL and tetany again around 6 to 7. Apnea around the same time. Seizures usually happen when the calcium levels are between 5.5 to 6. A rough estimate as to how do we convert into ionic is that you can divide it by 8. So if you're talking about 8 milligram per DL, roughly it will be like 1 millimole per liter as far as the ionic calcium level is concerned. Cardiomyopathy, again, a late effect. What about hypercalcemia? Irritability starts from around 12, polyuria from around 13, hypertension from around 13, dehydration sets in from around 14 milligram per DL, encephalopathy beyond 15 and 16, and these could be a severe situations, particularly seizures. So the manifestations will depend upon the calcium levels, but we need to be careful in terms of the situation wherein we are dealing with in this perspective. The 2-month-old boy with distress, hepatomegaly, cardiac failure, ejection fraction 30%, diagnosed as dilated cardiomyopathy, was admitted in the cardiac ICU because it was considered to be a cardiomyopathy. But then this was around 15 years ago, they found increased QT interval and then was found to be hypocalcemia because of vitamin D deficiency. So this is a situation we need to be really careful about. Any child with unexplained cardiac failure in the newborn period, think hypocalcemia, think hypoglycemia. And this could have been prevented if we had given enough of maternal and postnatal vitamin D. So now we've talked about physiology, pathophysiology, now we'll talk about assessment. And the key aspects to look at in any child who has a calcium problem, and we have to look at some of the basic investigations should be done in everybody, and they include blood levels of calcium, magnesium, phosphorus and alkaline phosphatase, urine level of calcium and phosphorus, and finally the hormone levels, the PTH and vitamin D, very rarely FGF23. So we'll talk about each and every level as to how do we do it and how do we interpret. So serum calcium should always be done in the morning in a fasting state, ideally. It should be a serum sample. The problem with that is that there is hypoalbuminemia, the level will be falsely low. So ionic calcium may be preferable in an ICU setting because of both hypoalbuminemia as well as the acid-base disturbance. And you may also have pseudo hypercalcemia because of high protein. So you have to be careful in these two situations. We can use these formulas to correct for calcium, which we discussed in that case. So for every 1 gram per liter, basically, which is a decrease in albumin, we have to add 0.8 milligram per dl in the calcium level. So this formula can be used to assess that. And as we know, the levels tend to fall by 24 hours and greater fall in the preterm period is noted. So we need to use different cutoffs for different ages. And these are the guidelines as to how do we use. So less than 1500 grams, the criteria is around 1 millimoles per liter. In ionic, we'll focus mainly on ionic because when we talk about sick children, most of us now have access to ionic. So less than 1500 grams, 1 millimole per liter. More than 1500, it goes to 1.1, while post-neonatal it is around 1.15. So these are the criteria when we need to worry about hypocalcemia. So the cutoffs for hypocalcemia are lower in the newborns, particularly who are low birth weight. Phosphorus levels are extremely important and they are most affected with dietary intake. So they should be done on a morning in a fasting state. The sample should be a serum sample. Again, we need to be careful that it is not a squeeze sample because phosphorus, like potassium and magnesium, is intracellular. And therefore, we can have a release of phosphorus and that could be a problem. It should not be squeeze sample at all. 8 specific levels of phosphorus should be taken, which we are giving here. And so in infancy, the levels can be really high, up to 8 milligrams per dl. And subsequently, the level comes down in the adulthood. Very important to remember, the reports we get usually will have adult cutoffs given. So often we will misdiagnose something as hyperphosphatemia when it may be actually be the normal situation in that perspective. Alkaline phosphatase, very important, is a marker of bone formation. It should be taken in the serum. It can come from the liver, bone and placenta, but in the absence of liver disease, usually total alkaline phosphatase is a good marker of bone function and bone formation. The levels can be very high in rickets, and particularly in the treatment phase, the levels can go up. They can also be high in hyperparathyroidism, but if we have undetectable level of alkaline phosphatase in the setting of hypercalcemia, we should think of hypophosphatasia as a possibility. So these are the levels. We need to remember that children tend to have a higher level as compared to adults. So always consider this. A lot of referrals come just because the ALP levels are high, but we have to look at the growing status of the child in this situation. 3-year-old boy with rickets, vitamin D was given 60,000 international units, complains of bone pain, alkaline phosphatase is high, calcium level is normal, and then he was labeled as refractory rickets. Do we agree? Definitely, we have to think of the most important part of the actual response to vitamin D is the line of healing which was present in this case, which basically means that alkaline phosphatase levels may go up during treatment of vitamin D deficiency, and they are not a reliable marker, so to speak, of lack of vitamin D response. Serum magnesium is extremely important and again should be done in the morning in fasting state. Should be, because of being intracellular, avoid tourniquet and squeeze sampling. Levels we need to use, either we use millimoles or milligram per dl. Levels less than 1.5 are considered to be significant. Usually less than 1.2 milligram per dl would be even more significant from a pathophysiological perspective. Urinary calcium excretion may be required in the setting of calcium evaluation for hypocalcemia, hypercalcemia, as well as for renal tubular acidosis. They should be done on a 24-hour sample, or we can use the second urinary sample, not the first. The second urinary sample on a spot sample can also be used. We can use 24-hour urinary calcium more than 4 milligram per kg per day, but because this time collection may be quite difficult, we can use a urinary calcium to creatinine ratio, and levels more than 0.25 milligram per milligram or 0.7 millimole per millimole is considered to be hypercalcemia in children. If the levels are high in a child with rickets, think of distal RTA. And in rickets, if they are low, think of vitamin D deficiency and vitamin D dependent rickets type 1 or 2. If you have hypocalcemia with hypercalciuria, considered calcium sensing receptor activating mutation, while if there is a hypercalcemia with hypocalciuria, think of a calcium sensing receptor defect. 4-year-old boy with tetany and low ionic calcium, phosphorus levels are high, PTH levels are low, so this looks like hypoparathyroidism, and the urinary calcium creatinine ratio is high. So this is an unusual situation, and this looks like a calcium sensing receptor defect. You need to be very careful in these new infants, because these children, because they will develop nephrocalcinosis very quickly in this situation. Urinary phosphorus excretion is important, particularly in the evaluation of hypophosphatemia and rickets. And this we can do using a fractional excretion of phosphorus, like we do for sodium. So urinary phosphorus upon plasma phosphorus into plasma creatinine upon urinary creatinine. And then we can calculate how much is actually being resorbed, which is the TRP. But this is also dependent on plasma phosphorus. So the best way to assess phosphorus excretion from the kidney is actually to look at the tubular maximum of phosphate for GFR, which is calculated based upon phosphorus and urinary phosphorus. And there are nomograms also which are available, which can be used to assess urinary phosphorus excretion. In general, because phosphorus is largely regulated at the level of kidneys, if you have low levels of phosphorus, it usually means that there is increased phosphorus excretion by the kidney. So we have 14-year-old boy with rickets, refractory rickets, and we see mainly lower limb involvement, a lot of these bone changes. And what we're looking here is that phosphorus levels were, he had low level of phosphorus, base excess was normal, blood gas was normal, calcium was normal, and PTH was normal. So this was a classical case of hypophosphatemic rickets. In the situation, we did a TMP GFR, which was very low. But if somebody has got 1.8 milligram of phosphorus, it would anyway mean that he is losing more on urine. You may actually skip this TMP GFR in this situation. What about parathyroid hormone? It is extremely important to evaluate of hypocalcemia, hypercalcemia, as we discussed. So low calcium, high phosphorus. Any case of hypercalcemia, rickets with high phosphorus, we have to look at PTH levels. Precaution again is that this is a highly thermolabile hormone. It is unstable. We have to transfer it immediately in ice, and intact PTH is being done in most cases. If we do not transfer in ice, the PTH levels will be low. So levels are 10 to 55. They should always be interpreted in the level of calcium. So if there is hypocalcemia, one would expect the PTH levels to be high. Normal PTH with hypocalcemia suggests hypoparathyroidism. Similarly, normal PTH with hypercalcemia suggests hyperparathyroidism. 3-month-old girl with seizures, ionic calcium of 3.2, phosphorus is low, PTH is low, diagnosis is hypoparathyroidism. But as we know, we expect phosphorus to be high in this situation, while in this situation it was low. So what looks like that this is vitamin D deficiency, and this PTH was not collected on ice, and therefore there is a inappropriate transport of PTH. So as discussed earlier, PTH should be interpreted in the light of calcium, low PTH, of course hypoparathyroidism, but even normal PTH, it could be hypoparathyroidism. High PTH with hypocalcemia is secondary hyperparathyroidism. Similarly, high calcium, high PTH is hyperparathyroidism. But if the PTH is normal, it is inappropriately high for the level of calcium. This is hyperparathyroidism. So PTH should always be thought of in the context of calcium level. What about vitamin D? Vitamin D levels should be assessed in the setting of hypocalcemia and low phosphorus levels. Rickets, nutritional status, the best marker is 25 hydroxyvitamin D, and levels should be 20 to 50 nanograms per ml. So there is no role of assessment of vitamin D. In this setting, there is no role of calcitriol to assess, because that can cause more confusion. So calcitriol is something which is often prescribed but of limited role, because calcitriol levels depend upon the PTH level. So these levels can be low, normal, or high in the setting of low vitamin D. They should only be done if there is hypocalcemia, low phosphorus, and normal vitamin D to rule out VDDR type 1 or type 2, or in children with rickets with high PTH and normal vitamin D to exclude for other situations. The pitfalls are that it is PTH dependent and the levels in infants can vary. So these are the ranges which we have to look for, age-specific ranges for calcitriol. So the key practice points, we've discussed a lot about physiology, a bit about pathophysiology and how to assess. So this will really form the basis of how to go ahead in terms of evaluating and managing a child with calcium disorders. So there is a key role of PTH and vitamin D. Phosphorus levels provide a clue in terms of diagnosis. There are significant changes in the perinatal period, and one needs to be careful in terms of monitoring for vitamin D. So this is something which is extremely important in this situation, which we need to be careful about in this situation. So just a few of the announcements which we want to make. So we are just coming up with the pediatric endocrinology textbook, which is available from our website. This basically is a comprehensive book which covers each and every aspect. So there are 42 chapters across 7 sections covering every aspect of endocrine physiology. And it is covering basically all the relevant parts for the pediatricians, including growth disorders, puberty, thyroid, calcium, electrolyte, and glucose. And this is a lot of these animations which we're using here are available there, and they make it much simple in terms of evaluation. It's using a lot of figures, a lot of colored illustrations, which really make it quite easy in that perspective. So if you look at the bone age, we have extensive amount of structure, and we're using pathophysiological models to assess etiology as far as algorithmic approaches which are available. There are also case vignettes. So every chapter will have around 10 cases which are there, as well as learning points. So this is something which is going to really help in terms of day-to-day management, and these are guided towards anybody who is dealing with pediatric endocrinology, be it pediatrician, neonatologist, pediatric endocrine trainee. And this you can order through our website, learning.growsociety.in, which is available there.
Please visit our website, learning.growsociety.in, the go-to place for pediatric endocrinology learning. Happy learning.